Instrumental swallowing assessments are exactly that, using instruments to visualize and assess swallowing function. There are two main instruments that are commonly used. The first is the Video Swallow Study, otherwise known as an MBS, or Modified Barium Swallow, or VFSS, the Video Fluoroscopic Swallow Study. And second is FEES, or Flexible Endoscopic Evaluation of Swallowing. Let's take a look at each of them. The Video Swallow Study uses fluoroscopy, or an X-ray movie, to look at swallowing. Patients will drink liquids and eat foods that have been mixed with barium, so it shows up on the X-ray. Here's an example of a normal swallow using this tool. FEES, or Flexible Endoscopic Evaluation of Swallowing, uses an endoscope that is inserted through the floor of the nasal cavity and allows visualization of the pharynx. During the swallow, there is what is called a whiteout period, but milliseconds before and after the swallow can be seen. And if aspiration occurred during the whiteout swallow period, is generally visible in the trachea. Both these tools are sensitive and specific and considered gold standards of the assessment of swallowing. In this presentation, we're going to discuss the problem in skilled nursing facilities related to swallow studies, who's affected by it, and the cost associated with this problem. To outline a solution, we'll identify current leadership and policy related to this problem, then propose a framework for progress and how to implement this change. In March of 2019, the ASHA Leader featured an article about instrumental swallowing assessments in skilled nursing and long-term care. They stated that some facilities do not allow their SLPs to order instrumental swallowing assessments, and without access to these tools, providing evidence-based practices is extremely difficult for the SLP.
By the late Stephen Leader, and it was called Comparing Simultaneous Clinical Swallow Evaluations and FEES, Findings and Consequences. And here I've just highlighted a few of the key points that I wanted to talk about. The research goal was to conduct blinded ratings of simultaneously recorded bedside and FEES using the exact same swallows, thereby allowing for control of both temporal issues and testing environments. The results: no consistent agreement was found between the clinical bedside evaluation and the FEES raters regarding pharyngeal and laryngeal anatomy and physiology, bolus flow characteristics, and oral diet recommendations. And really, they talked about that the clinical bedside evaluation does not have good clinical utility for determining pharyngeal dysphagia. It does not say that the clinical swallow evaluation does not have clinical utility, but just not for determining pharyngeal dysphagia. So this is an example of a patient who is silently aspirating. So with a clinical bedside evaluation, this isn't something that you would be able to necessarily see. So I'm going to play this for you. And you could see that first swallow, a lot of residue, and that second swallow, aspiration on the anterior tracheal wall. And again, something that you would not see with a clinical bedside evaluation. This is another tool that we have in our toolbox, the FEES. And so I'm going to play this for you just so that you can see another example.
So take a look at your voice box, Erin. Do you see that there's a little bit of saliva in there? Okay. So what I want you, good, you beat me to it. So you gave a big hard swallow to get rid of some of that. That's awesome. Do you feel like anything's stuck in your throat, Erin, or is it feeling clear? Yes, the scope is there. But do you feel any saliva sitting in your throat, or does it feel clear? Feels clear. And it looks clear, too, right? We're not seeing anything pink. All right, here we go. One piece of peach. There it is. Does it feel like it's all gone?
Now that you're familiar with instrumental swallowing assessments, both the video swallow and FEES, let's compare it to the clinical bedside swallow assessment, which is often the only assessment SLPs are able to do in skilled nursing facilities.
Alright, I'm just going to check your swallow with different consistencies and different types of food. Alright, say off for me. Thank you. Thank you. Alright, awesome. Say off for me. Alright, thanks.
How does the SLP determine if someone is silently aspirating? How much and how often are they aspirating? And what textures are problematic? Thin liquids or solid foods? The answer is they don't, because no one has X-ray vision. And this is why current research is recommending the clinical bedside assessment be considered as just a screening tool, not a full assessment for pharyngeal dysphagia. Without instrumental assessment, research indicates SLPs miss up to 40% of the patients who are aspirating and recommend incorrect diets 68% of the time following a clinical bedside assessment. In other areas of medicine, we used advanced technology for diagnosing health problems, coming a long way from the old feel and guess strategy. So why are SLPs in skilled nursing expected to compromise their practice and attempt to diagnose pharyngeal dysphagia using outdated practices?
Who is affected? There are about 15 million people in the United States with dysphagia and an additional million people who are diagnosed with dysphagia each year. The ongoing challenge of healthcare has been to provide increasingly higher levels of care while maintaining tight financial budgets. A second area of concern or cause would be increasing the use of instrumentation for dysphagia evaluation and treatment, and SNFs may possibly increase initial healthcare costs.
And then there were 5 conditions that all account for 78% of all 30-day SNF rehospitalizations that could have been avoidable with careful monitoring, adherence to patient fluid and nutrition intake, and following appropriate positioning of residents with swallowing problems to avoid aspiration that could lead to pneumonia. So it's CHF, URI, UTI, sepsis, and electrolyte imbalance. And then what is the cost really to the patient? Patients really don't like the thickened liquids. It's not palatable for them, so they don't drink as much. And maybe they have the potential for dehydration. And actually, dehydration has been linked with people being on thickened liquids and having electrolyte imbalance and UTIs, again, due to the decreased palatability and patients just refusing to abide by having the thickened liquids. We really talk about the actual cost of treating dysphagia patients, and statistics tell me that it can cost up to $2,000 to $7,000 annually to keep one institutionalized patient on thickened liquids for 1 year. The cost of managing a patient with a feeding tube, which for many has been the primary treatment option for dysphagia, is reported to average over $31,000 per year, with 70% of patients reporting serious medical complications even having the tube. And then, of course, aspiration pneumonia is the leading cause of death and most common complications arising from dysphagia for our long-term care residents.
So let's take a minute to compare the cost of taking action using instrumental swallowing assessments to the cost of inaction, continuing to limit or deny access to instrumental swallowing assessments. Nationwide, the cost of a video swallow is approximately $1,200, and often patients may rely on the skilled nursing facility for transportation. More recently, FEES, the endoscopic evaluation, is being used because the equipment is portable and it can be done at bedside, which means no transportation cost. The national average expense for FEES is $350.
There are so many benefits to ensure that dysphagia patients are evaluated with objective measures. And here are just a few of those benefits. Providing best practice dysphagia care, improved quality of life for our patients, less cost to facilities and insurance companies, adhering to current guidelines from ASHA, from Medicare, from the American Board of Swallowing and Swallowing Disorders, as well as from the Dysphagia Research Society. And relying on objective clinical data and not just clinician intuition. And then finally, empowering all dysphagia clinicians to really use the appropriate tools that we have in our toolkit when suspecting a patient that has especially a pharyngeal or esophageal dysphagia.
Now, let's compare this with the cost of taking no action.
What are the costs of taking no actions? Well, sadly, dysphagia patients would be on more restrictive diets than they really need to be, and maybe for prolonged periods of time if you can't get access to instrumentation in a timely manner. A reduced quality of life for patients if they are restricted in their diets, if they're not able to have thin liquids, or if they require tube feedings. And then really no action is not abiding by the current ASHA, Medicare, ABSSD, and DRS recommendations for use of swallow instrumentation. And really, we're not providing evidence-based care. And there will be increased healthcare costs to both the patient and the facility with regard to tube feeding requirements, thickened liquid requirements. So all of that needs to be taken into consideration.
So when we talk about how leadership is involved in this situation, we look at two leadership styles. One is our great man leadership style, where the skilled nursing facility administration is dictating that the bedside swallow study will be used, that policy is not going to be adhered to, and therefore the SLP must abide. This results in less opportunity for the SLP to advocate for use of instrumentation. There's a greater risk of patient safety being compromised and lack of patient-centered care. On the other hand, there's another leadership style that is being used, the transformational leadership, which is seen more in the acute setting as instrumentation is readily available as opposed to a skilled nursing facility. Here, the SLP has greater opportunity to advocate for use of instrumentation when warranted. There's an increased adherence to policy, there's less risk of patient safety being compromised, and the focus is on patient-centered care.
What theoretical framework would be more appropriate to the creation and implementation of policy change? Well, being that there are already standing policies, we selected the policy triangle framework. This framework was selected because, as mentioned, there are already standing policies. The policies just lack adherence. Force-field analysis allows for the discussion of viable supportive factors for change. One supportive factor for change would be increasing the liability by both the service provider as well as the medical entity. Force-field analysis also warrants the identification of causal factors against change. And one hot topic regarding causal factors against change would be the cost of utilization of instrumentation for dysphagia management in SNF settings.
Now here are some examples regarding lack of policy and adherence to policy. So lack of policy adherence. This situation was a 20-year-old male eating chicken. He complained of pain in the neck and had difficulties eating. He saw two doctors, each missed it and said nothing appeared to be wrong with him. He went into cardiac arrest. A CAT scan revealed obstruction. The patient was put on life support, went into septic shock, and you can click on the link to find out what happened. This example, however, is a positive example, where a 51-year-old male complained of inability to swallow solid foods and some liquids. The physical exam of head and neck showed no evidence of pharyngeal concerns. Palpation of the laryngeal area on the left side indicated some tenderness. The CT showed inflammation, and a laryngoscopy showed obstruction. You can click on the link to find out what the results are. And our other example, adherence to policy, is a 65-year-old woman coughing up blood in China. She complained of something moving in her throat, so a bronchoscopy was ordered. And you can click on the link to find out what was found in the throat. When lack of policy adherence compromises patient safety and affects quality of life, we as SLPs have to ask ourselves these questions. Would I want to have my quality of life compromised? Would I want to risk the safety of my family members' health because of lack of instrumentation? How can I ethically abide by an administration decision when I know it is wrong? Does this decision violate ASHA's Code of Ethics? And what am I going to do about it? You know, the old saying is what bothers you the most is what you are meant to change. And sometimes you are the solution to someone else's problem.
I really feel like there are no feasible alternatives to not visualizing the pharyngeal, laryngeal, and cervical esophageal anatomy that you're evaluating. You would never ask a neurologist or a neurosurgeon to do surgery on someone's brain when they didn't actually get to see what was happening inside with imaging. All alternatives require some level of presumption or guesswork regarding the actual pharyngeal function. And you know, patients would be on modified diets maybe for prolonged periods of time while clinicians systematically attempts various consistencies of food and liquid to assess their tolerance while closely monitoring their respiratory status and signs of infection.
By increasing the liability for doctors, therapists, facilities, and insurance affiliates, that would automatically shift the focus of care from cost of care to quality of patient care. This will take us back to evidence-based practice standards, because these standards are already in place. They just need to be adhered to.
So what are our solutions? How can this policy be changed? Well, adhere to it. Adherence is required. Advocate for adherence to set policy of use of instrumentation by getting the word out, communication between staff and administration, educate the state surveyors and the legislators. Also, advocate for improvement in patient care and quality of life. We research and we network through our ASHA special interest groups, our state commissions and organizations, the Joint Commission for Transforming Healthcare, the Commission on Accreditation of Rehab Facilities, which is CARF, has on their resource page under the International Advocacy Council, the American Council of Rehab Medicine Special Interests and Networking Groups. We can establish a coalition for policy change, SLPs Unite. We can also present the facts at our state conventions, at the ASHA Connect Convention, and our national convention. What can we conclude? Policy set by ASHA, according to the clinical indicators of instrumental assessment of dysphagia, in most cases is not being followed. Due to shortened hospital stays, more acute patients seem to be admitted to the skilled nursing facilities. The clinical bedside swallow studies are being used to diagnose dysphagia due to lack of funding and lack of education in these skilled nursing facilities. Well, you can't diagnose what you can't see, so a bedside only works for the oral stage. Patient care is being compromised as a result of this by administration not following policy. And the consequences of this action are rehospitalizations of patients or death.